Following on from last week, I'm going to do the second part of the Interpreting Bloods lecture. So last week we looked at FBCs and U's. This week we are going to do LFTs and clotting. And then at the end we're just going to whiz through some of the other things that might come up, but not in as much detail. So straight on with the cases. So a 36-year-old man is referred to you in A&E because he is noted to be jaundiced. He's been feeling generally unwell recently with some diarrhea and vomiting. His LFTs show the following. So what's the abnormalities here? How can we describe that blood picture? Someone said it? A bit louder? So it's a hyperbilirubinemia, yeah, and it's an isolated hyperbilirubinemia. The rest of the values are completely normal. What might be interesting to know about that bilirubinemia? Yeah, whether it's conjugated or unconjugated. It's probably less relevant in this age group, certainly in paediatrics. That is an important distinction to make. This chap has an unconjugated bilirubinemia. And what could be the cause of this? So hemolysis, yeah, a very common cause of an isolated hyperbilirubinemia. Another common cause? I heard it somewhere muttered. Gilbert's or Gilbert, if you like your French. Absolutely. So there's not many causes of an isolated hyperbilirubinemia. Certainly the most common are hemolysis and Gilbert syndrome. Obviously with hemolysis you're getting excess breakdown of red cells, you're getting increased bilirubin, and the liver can't quite keep up with the conjugation and excretion. Gilbert syndrome is a really, really common disorder, which just makes the enzyme gluconeoyltransferase that is part of that conjugation process is slightly defective. So in instances of illness, then people can become jaundiced or get a raised bilirubin. It actually has no impact, there's no significance to it. In fact, I think there's a study that shows that it decreases your risk of cardiovascular disease for some reason if you have Gilbert syndrome. The other causes are rarer. So obviously, well, not the next one, benign neonatal jaundice is very common. Lots of babies get jaundice. Most commonly it's just because of breast milk, so breastfed babies are more likely to be jaundiced. And then there's some drugs, so rifampicin. The others, Crigler-Najjar, Gibbon-Johnson, Rotor syndrome, the glycogen storage diseases, they're very quite rare genetic disorders. Crigler-Najjar is basically an absence of gluconeoyltransferase. You just can't conjugate any bilirubin, so it builds up. And Gibbon-Johnson and Rotor syndromes are problems with excretion of bilirubin out of the cell. So it gets conjugated, but it can't leave the hepatocytes to be excreted, so it builds up in the blood, so you get a conjugated hyperbilirubinemia. Right, case 9, a 30-year-old woman presents to your GP practice with a 1-month history of upper abdominal pain. Her LFTs show the following. And what's abnormal? How can we describe it? Anyone? So what's the biggest abnormality? So the ALP is markedly raised, yeah. ALT, AST is a bit raised. The gamma GT is also quite raised. Bilirubin is marginally raised. The albumin is normal. So broadly speaking, what kind of picture is that? Yeah, so a cholestatic kind of obstructive picture. You know, you'll always get abnormalities in all of the things with a hepatitis or obstruction in the biliary tree, but classically speaking, you can describe this as a cholestatic picture, and exams are always kind of the classical textbook thing. So if you've got a marked increase in the ALP and the gamma GT over the ALT and AST, then you can say it's a kind of cholestatic picture. The ALP are enzymes that line the biliary ducts, so if you get obstruction there, irritation there, that's why you get a more marked increase in the ALP and the gamma GT. Gamma GT are also a good marker for alcohol abuse. So what would be important to know about this patient? So alcohol intake, yeah. So whether she's jaundice, yeah. Fever, yeah. So you want to know her clinical. If she's febrile, what would you be worried about? Cholangitis, yeah. So what's the famous triad for cholangitis? What's Charcot's triad? Someone confidently say all three? And jaundice, yeah. So Charcot's triad is the presence of jaundice, right upper quadrant pain, and fevers with rigors, and that's ascending cholangitis until proven otherwise. But presuming this patient's well, then you can perhaps refer for an ultrasound, refer to the general surgeons. What might you expect to find on examination? What clinical sign would you try to elicit on this lady? Murphy's sign. And what's Murphy's sign? That's half of it, yeah. So Murphy's sign is tenderness on palpation of the right upper quadrant during inspiration that's not reproduced on palpation of the left upper quadrant. So if they've got pain both sides when they breathe in, that's not Murphy's sign. They might still have gallstones and things, but Murphy's sign is just on inspiration when palpating the right upper quadrant. Good. So the pain now worsens and she becomes quite nauseous and attends A&E. We've mentioned one of the things we'd be worried about. What is another thing we might be worried about? So gallstones are probably the likeliest cause, they're the commonest cause of this sort of thing. What can gallstones lead to that is also worrying? Pancreatitis, absolutely. So you'd probably repeat the bloods and add on amylase. Would these blood results be suggestive of a pancreatitis? No? So generally we say that if it's raised over 3 times the upper limit of normal, then that is a good going sign of pancreatitis. It can be a lot more than that. It's not just pancreatitis that can cause a raise in the amylase. There's all of these other things. Most hospitals will use the amylase. Lipase is another marker of it, but it's a rarer one. Good. So a 45-year-old woman, and these are her blood results. How can we describe them? So, yeah, a hepatitic kind of transaminitis picture. What could be the cause here? I'll hone the question further. So this is a really large rise in the ALT and AST. It's in the thousands. There's 4 main causes of a transaminitis that will push your markers into the thousands. Can we name all 4? Anyone? So, yeah, an acute viral hepatitis is one. Cancer's not one, no. Drug-induced, yeah, so kind of paracetamol overdose, toxicity from amiodarone and things can cause that. 2 more. So autoimmune hepatitis, good. And 1 more, not one you generally think about for the liver, but you think about for the heart. So an ischemic hepatitis. So you can get, as you would get a myocardial ischemia, you can get gut ischemia, you can also get a liver ischemia. And if you get an infarct in the liver, that will shoot up your markers as well. So they're the 4 main causes of a huge transaminitis. And that is basically all I was going to go through for them. So that's just a summary table to just go over what we've discussed. The thing we haven't touched on is the albumin. Obviously, we do albumin as part of LFTs because it's a marker of synthetic function of the liver. And what's another synthetic function of the liver that we test for? Clotting. So yeah, so if someone's you're worried about the liver function, then it's important to do an INR as well. Just one more thing to note. If someone's got really severe chronic liver disease, they've got a cirrhosed liver, their AST and ALT might be normal. because actually they've lost so much of their liver mass that they can't actually produce those enzymes. So don't be fooled by someone that's got all the signs of chronic liver disease, but the liver enzymes are normal. It's just actually, it might be that they just can't produce them anymore because the liver is so bad. Good. Now, clotting. I wasn't here last week, as you know, so hopefully Dr. Greaves served you well going through haematology. I'm sure he touched on this, which means you'll all remember it fully. So, for the clotting, in the first year I did the cases first, and everyone stared blankly at me. And then, so I've turned it around to just try and point out the key things for the clotting cascade first, and then we can think about it with the cases. So as you know, vitamin K is an important vitamin for the clotting cascade. Warfarin antagonises vitamin K, which is an anticoagulant. So vitamin K is important for lots of these things. Things to highlight. So the extrinsic pathway is just this with factor 7. And this is what you're testing when you do a PT. So this is effectively what the INR is testing. So the prothrombin time is you basically add in some tissue factor and then you see how long it takes to clot. So it's testing the extrinsic pathway and the final common pathway. And that's the PT. So that is what the INR is testing. The APTT, the other one, the activated partial thromboplastin time, they all have really stupid names. That's testing the intrinsic and the final common pathway. The intrinsic pathway is where all your haemophilias affect. So you can get a factor 7 deficiency, but it's not been shown to have kind of any clinical significance because you've got a function in an intrinsic pathway. But the intrinsic pathway is where your haemophilias affect, and is tested by the APTT. The thrombin time is just testing the final common pathway. You basically add thrombin to it to see if the fibrinogen forms the fibrin. So the thrombin time is just testing the final common pathway. They're the main things to draw, I think. This antithrombin is what heparin acts on. So heparin is an indirect antithrombin agonist. And what it does, it binds to the antithrombin, changes its conformation and increases its function. Which obviously, because it's an inhibitor of factor 10 and thrombin, is an anticoagulant. Now, in terms of the difference between low molecular weight heparin and unfractioned heparin, so unfractionated heparin are large, huge clumps of heparin molecules. Because they're larger, that has a greater effect on both factor 10 and thrombin. The low molecular weight heparins, as their name suggests, are smaller molecules, and they basically exert their effect on factor 10. So they don't have so much effect on thrombin. Now, why is that relevant? Because one way you monitor unfractionated heparin therapy is by measuring the APTT, because it's affecting this pathway, but low molecular weight heparins won't necessarily prolong the APTT. They might just a little bit immediately after giving them, but generally you can't use the APTT as a monitoring for low molecular weight heparins. If you do need to monitor for therapeutic accuracy, then you do an anti-10A level. You literally just look for the level of the antithrombin in the blood. Put those up there for people that can't remember their Roman numerals. But we'll go through the cases and kind of draw on that. Again, there's this summary table that you can go away and read about. It just summarizes what all the different parts of it are. As I mentioned, the INR is basically just a marker of the prothrombin time. Because the reagents used in labs and the normal ranges vary so widely between labs for clotting, the INR is basically just an international standardization of the prothrombin time, so it's easy to treat people and all the different causes. This little note here about the antiphospholipid antibody lupus anticoagulant, that's quite complex honours level stuff. As you know, people with antiphospholipid syndrome are more prone to thrombosis and also miscarriages and things. The reagent there, the antiphospholipid antibody, weirdly increases the APTT, but they're more prone to clots. That's because of another effect it has on platelets. So that's, if you want to read about that, then do, but that's quite a complex thing, and I wouldn't worry too much about it. You can do specific factor assays. Mostly you'll only be allowed to get away with doing an anti-10, anti-10A without haematologist approval. Fine, so let's go through some cases and see how much of that sunk in. So a 4-year-old boy is referred to you by his GP after concerns relating to non-accidental injury. He appears to have a number of bruises which his parents cannot account for. Like a good paediatrician, you undertake some clotting studies and you find the following. So what's the main abnormality here? So the APTT is markedly raised. What could be the cause here? A haemophilia, absolutely. So as you remember, that's affecting the intrinsic pathway, which the APTT is a measurement of. He's got prolonged, he's of that age, he's got unexplained bruising. A haemophilia would be a very good reasonable differential, and then you could do the specific factor assays to try and find all the genetic studies. So 2 70-year-old ladies are sitting in hospital. Bloods are taken at 7. In bed 1, these are her results. So what's the main abnormality? So a prolonged PT and therefore a prolonged INR. What do you think might be happening here? Warfarin therapy, yeah. So everyone gets their warfarin at 6 p.m. Bloods are taken after. The APTT is just prolonged because you can get a slight raise in the APTT immediately after taking warfarin, but generally it will affect the PT. Next to her. What do you think is going on here? So she's just had a usual dose of low molecular weight heparin, which everyone pretty much gets in hospitals. So it doesn't really affect anything. It will increase the thrombin time slightly because it's affecting that 10A, the final common pathway. But generally you don't get much changes on your clotting profile with low molecular weight heparin. Good. So a 16-year-old boy is brought in by ambulance after a motorcycle accident. He is unconscious, he has an open fracture, which is hemorrhaging. He undergoes surgery and then taken to ITU. Post-operatively, he is noted to be bleeding from his wound site, the central line site, and his nose. What are we worried about here? Is that consistent with DIC? Yeah, basically everything goes awry. What does DIC stand for? Yeah, so disseminated intravascular coagulation, or as others refer it to as death is coming. It's a really severe thing. There's basically no treatment for it. You effectively just have to give supportive therapy. What DIC is basically a perverse relationship where you've had an insult to the body. There's a number of causes there, trauma, severe infection. Clotting starts in some of the blood vessels. You get widespread consumption of your clotting factors, which then means you can't you can't form a clot where you actually need one. So you've got these abnormal clots forming, which then means you can't clot where you need. So you get this huge dissemination of coagulopathy, and all your markers basically go awry, and it's really bad. You can give replacement factors and things, but there's no specific cure that you can just switch DIC off. It's all supportive management. Here's just a summary table again of the kind of things that you might expect in different deficiencies and medications. Useful to mull over again in your own time. Right, so that's the main bulk. I'm just going to quickly rush through some other things that they might throw at you, just so you're aware. So D-dimers. So these will be so difficult. Most of you will end up doing an A&E job, and you'll spend most of your time deciding about whether someone has a DVT or PE, and then you'll get the D-dimers back, and they'll just be marginally raised, and it'll make your life an absolute nightmare. What are D-dimers? D-dimers are effectively just degradation products of a clot. They're degradation products of fibrin. Obviously, an important part of the clotting cascade is plasmin and the degradation of clots, because otherwise we'll just all clot up inside and would die. So breaking down of clots is important, and the D-dimer is basically a marker that clots are being broken down. They are raised in infection, malignancy, post-operatively, and in pregnancy, which complicates matters because when you're most likely to get a clot, it's when you're post-operative or you're pregnant. So you be careful with D-dimers. Don't just routinely just request them on everyone. What they can do, if they're negative with a low suspicion of a DVT or PE, is kind of comforting. So if the clinical judgment is that it's not likely to be a DVT and the D-dimers are negative, then you can be quite safe in saying that that isn't a DVT. What is the scoring system we use for DVT and PE? Wells score, yeah. So definitely know your Wells score. I haven't put it up, but it's not that hard to learn. But a negative D-dimer, if your suspicion is high, doesn't rule it out. So if you see someone with a massive swollen leg who's just been off on a transatlantic flight and she takes the oral contraceptive pill and you're really concerned she's got a D-dimer, but you're worried she's got a DVT, the D-dimer's not raised, then it doesn't prove anything. Your clinical judgment, as with most things, trumps any lab test. So this little flowchart basically summarizes that. But the thing is, they're not the be-all and end-all of clinical medicine, so make sure you always look at them in the context of the clinical picture. Cardiac enzymes, basically all hospitals, I think, now are using the troponins. Again, a heart attack is not the only thing that causes a rise in the troponins. They often just get done on every patient walking into A&E, and that can cloud the picture. You end up speaking to the cardiology reg who are really not interested. If there's no evidence of a myocardial infarction, then don't do them. They can be raised in sepsis, they can be raised in renal failure, anything affecting the heart, so if they've got a myocarditis or atrial fibrillation, all of these can cause a rise in the troponins. So again, only request them if you're specifically trying to rule in or out a myocardial infarction or angina type picture. Some other, the older ones that you would use were lactate dehydrogenase and creatinine kinase. Probably not worth knowing about much now. So erythrocyte sedimentation rate is a marker of inflammation, raised in lots of things, and you can get false results with them. I'm not going to read through the table, but you can look at that. CRP, as we've mentioned before, that's an acute phase reactant. The C stands for the capsular antigen of the streptococcus. So typically you get a huge rise in CRP with bacterial infections, but generally anything causing inflammation in the body can cause a rise in the CRP levels. The other thing with CRP is that there's generally a lag effect because it's an acute phase reactant. Once that insult to the body has occurred, there's the gene transcription and thing to create a rise in the CRP that can lag behind the clinical picture. So if you've got someone again that you think's got a nasty infection but the CRP's 4, that doesn't mean that you hold back from antibiotics and things if you need them, because actually if you repeat it again in 2 days it might be 120. So that is a lag effect to bear in mind. The other acute phase reactants that we've touched on, these are all things that go up. Ferritin, the point from last week that you can't really rely on doing a ferritin level as a marker of iron status in someone that's acutely unwell because it might just be up because of their illness. TFTs, these 2 summary tables here to go through all the different kind of combinations between TSH and 3T4 and T3. I'm not going to labour the point. Parathyroid hormone, calcium phosphate, calcium metabolism. This is beautiful final stuff. There'll always be a question about this kind of thing in finals. Here's the table that summarizes all of the things. I wouldn't be able to do this justice in 2 minutes, but go away, read up about these things, the difference between primary hyperparathyroidism and secondary hyperparathyroidism, where vitamin D fits into this, all the pseudos. Go away, absorb that, learn about that. Did someone say? Was there a question? No. Immunoglobulin allotypes, as I touched on in my antibiotic lecture. IgG is a kind of a marker of past infection. If you're there's certain times that you might want to know if they've got an active infection, so sometimes EBV serology, and you're looking for the IgM, because IgM is the first allotype that's created in an infection. So if you're IgM positive, then it's a good sign that there's an acute infection going on. IgG just means that you've had past infection with that agent. All of the autoimmune antibodies. Now, I think these slides are trumped by, last year we had a rheumatology talk on our specialty day, and by Dr. Amy Sanford. That lecture was fantastic. It's online. We unfortunately couldn't squeeze her into the schedule this year, but it's a really revision-friendly lecture about rheumatology and all of the systemic disorders as well. So I'll make sure the link to that is nice and clear, but definitely worth watching at home, the rheumatology lecture. And she goes through all of those things. Just quickly, last couple of minutes. Sometimes it's probably more F1-y, but you'll be on the ward round and the consultant will say, do a liver screen, do an anemia workup, and you're not sure what that is. So I want people to shout out what they think are the components of these tests. So I always forget which ones come up first, but liver screen first. What is part of a liver screen? LFTs, good start. So albumin, yeah, clotting, someone said. So yeah, a hepatitis screen, so looking for viral hepatitis screen. You can also do, I'll take autoimmune screen in that as well. Ferritin. Any more weird and wonderful ones? Ceruloplasmin, copper. I think most people have said them. So your standard ones are here. If you're worried that they've got a hepatitis going on, these are justified. Ferritin, the ceruloplasmin, copper metabolism, alpha-fetoprotein if you're worried about cancer, and alpha-1 antitrypsin if it's indicated. So anemia, FBCs, blood film, good. The hematinics, what forms hematinics? Ferritin, folate, B12, I heard total iron binding capacity there as well. Yeah, good. One I mentioned last week that people don't often think about. Coombs, yeah, so Coombs test is looking for antibodies on the red cells to see if there's an autoimmune kind of hemolytic picture going on. Celiac serology, I mentioned, is in the guidelines, but can come on at any age and causes malabsorption and can cause an anemia. And depending on the indication, you might do electrophoresis looking for sickle cell or thalassemias. Renal workup. Using these, good. I've kind of cheated here, so it's always important to look in the urine for renal disease, so doing a urine dip, and you can look at the urine electrolytes and proteins as well. The bone profile, what's in a bone profile? Calcium, phosphate, ALP, and depending on what they show, you might do a vitamin D as well. And then the septic screen, the big one. So what's the sepsis 6? 3 in, 3 out. So the 3 out are lactate, blood cultures, and urine output. And the 3 things you give: antibiotics, oxygen, and fluids. And then looking for an infection. So what things are you going to do? Chest X-ray, urine dip, good. Swab anything that's oozing pus, and if indicated, do a lumbar puncture as well. Good. This is what you hope your patients are. I call these blue-blooded patients. They're very, very rare because all the values are blue and normal. What you generally get is this sort of thing, where everything's red, everything looks horrible. But if you just break down the components, looking at the big important values, trying to thinking about what is the cause, and then looking at the more detailed things to see if that sways you one way or another, blood tests are easy. Good. Any questions? No, as always, I'm around afterwards if you want to come and ask me a question in between the lectures. I'll hand over to Will. Thank you.